Hi, I'm Dr. Andrew Davis. I am a vitreoretinal surgeon, currently employed here in Salt Lake City at Salt Lake Retina, and glad to be with you guys today. We're going to go through the basics of doing an ophthalmic exam, focusing specifically on the posterior segment exam of the eye and the retina. I'm a retina specialist, so that's what I do is I look at retinas. And what I'm going to try to do during this process is to give you little keys on how to manipulate the slit lamp and the instrumentation that we use in ophthalmology to be able to fine tune in to different parts of the retinal exam. And by taking the time to learn how to use the instrumentation, the lenses, the indirect, the slit lamp, it'll help you as the eye specialist to be able to properly diagnose diseases. And more importantly, by doing things in a step-by-step process, you'll better be able to follow patients, and having seen them once, next time you see them again, you'll be able to monitor for progression. Hopefully positive changes, although you'll also be able to see negative changes. And so it's worth the time to learn how to use the instruments properly. And so in our discussion today, that's what we're going to do, is I'm going to focus in on how to use the instruments and hopefully give you a few keys that you can practice with in the clinic and while you're in your training program. So let's go. We have our patient here. Anytime you see a patient, they're, at least in my world, they're going to be dilated. And so some of the parts of the end, the vision, the pressure, the pupils will already have been done. So I'm going to skip past those. I think one of the important concepts of doing an eye exam is to do it the same way every single time. So most things in ophthalmology, when we do the exam, we go from left to right. So every part of the exam, from outside the eye to all the way to the back, usually going to start on the left side, go to the right side. And I think that's important so that you form a repetitive pattern that you follow every single time. And by doing so and doing the exam the same way every time, you're less likely to miss things. And the concept is to try not to miss things, because we want to diagnose things and then help people. So vision, pressure, pupils, everything has already been done. My patients are usually dilated. And so we'll start into the slit lamp exam. So first thing you're going to do is you want to make sure your patient is somewhat relaxed. Patients will be very anxious. You want to let them know that you care about them. And so I always kind of tell patients that we're going to be doing a slit lamp exam, and I try to make sure they're comfortable. My patient population is generally a little bit more elderly, and so you want to make sure that their back, their neck, and things aren't contorted. If they're comfortable in the slit lamp, you're going to be comfortable and be able to spend more time trying to find the diseases. So first thing you'll do is bring the slit lamp over towards the patient. You'll kind of look where they are. The chin rest, I always eyeball where their chin is, and I'll bring it down to their level. However, you'll see a black mark here on the slit lamp. That needs to be level with the lateral canthus, or the lateral part of where the two eyelids come together. And so you're going to be lining that up so that it'll be their right eye is lined up with this black mark. And so that's one of the first key parts of getting a patient into the slit lamp. So you ask them to please come forward here, chin down in here, forehead up against the headrest. It's important they try to keep their head up against the headrest. You don't have to hound it too much. It's not the end of the world. And then I'm looking, you can't see it right now, but I'm currently looking at that black mark on the right side, and I'm looking at the patient's lateral canthus, and I'm going to make sure it's lined up. And it's nicely lined up right there. So next thing I'll do is there are different settings on the power of the beam itself. I usually set it on the half. There's a half and a 1. You don't need to blast them with light, but at the same time, you brought them here to do an eye exam, so you might as well make sure you have enough light to be able to see. Sometimes patients will be light sensitive. Their pupils are dilated, they may have inflammation or redness, or for whatever reason they may be light sensitive. But I do think it's important to make sure you use enough light so you can see, and then just be patient with the patient to make sure that you don't blast them with light too bad. So as a general rule, you're going to start with the right eye first and then do the left eye. And you look at the eyelids, and then you look at the conjunctiva, and then the cornea, and then the anterior chamber, and then the iris, and then the lens, and then you go back to the fun part of the exam, the retina exam. So make sure you concentrate on those first initial things. But as a retina specialist, I look at those areas to make sure they look okay, and then I'm really thinking about getting back to where the fun starts, which is behind the iris. All right, so first things first, you'll notice on the slit lamp, There's a joystick down below that can bring things into focus by moving it forward and back. And also you can move it left to right, and then you can spin it, and spinning it raises it up and down so you can get the eye and level. Also on the slit lamp, these are the main two knobs you're going to use. This upper knob that controls the lateral movement of the beam, the side-to-side movement of the beam. It also increases the width. And so by spinning the knob, and you can actually go all the way in and all the way out and spin it all the way around, you widen the beam. And so at different parts of the exam, you're going to widen or narrow the beam depending on what you're looking at. Also at the top here, it gives a size of the beam. So this increases the width, this increases the height. The knob that's up here at the top increases the height of the beam. On the slit lamp itself, it actually gives a millimeter measurement. So let's say that you're measuring the size of a corneal abrasion, or more importantly for me as a retina specialist, if you're looking at the size of a hyphema, which is blood buildup in the anterior chamber, you can actually measure the size of that hyphema or how tall it is, and then record that down so that later on you can record that, oh, it was 5 millimeter hyphema this week, and then a week later it went down to 3 millimeters. So obviously having less hyphema is better than more hyphema, so you can track that. That's especially important with looking at corneal ulcers or corneal abrasions or things like that. But in the retina world, we use it especially to measure the size of hyphemas or blood in the anterior chamber. So I'm just going to start her exam on her right eye. I start out by looking at her eyelids, and then I look at the conjunctiva and then the cornea. When you come to your cornea exam, that'll be a time where you start to narrow the beam. After the cornea, you're going to look at the anterior chamber, and in the retina world, we do a lot of uveitis or inflammation inside of the eye exams. And so to look in the anterior chamber, you're going to narrow the beam, you're going to make it thin and narrow and focus in on the iris. And once you have the iris border or the pupillary border nice and focused, you can pull back a little bit. Also, you want to turn the beam up, and that will allow you, by focusing on the iris border, having a focus and then pulling back just a little bit or focusing out, that will allow you to see if there's any inflammation in the anterior chamber, and this patient doesn't have any inflammation in her anterior chamber. So after looking at the cornea, then the anterior chamber, the iris itself, then you'll look at the lens and look for signs of cataractus changes in the lens. And then after the lens, you'll look back into where, like I say, where the fun starts in the posterior segment exam of the eye. One of the things with patients that I will always look at, and I think is critical in doing a retina exam, is to look at their vitreous. And you can see the vitreous and the fibers or the collagen fibers of the vitreous right in the space behind the iris. It's a good place to see that. It'll allow you to look for blood there, inflammation, and also for age-related or synuretic changes of the vitreous. And I'll look at that every single exam, no matter what I'm doing, and that can give me signs of or an idea if there may be some sort of pathology backed by the retina. One of the common exams that we do in the retina world is when a patient has a new onset of flashing light and floaters. And if they were to have a tear in their retina, the retinal tear would release pigment cells or RPE cells into the vitreous, and that would look like a tobacco dust or little teeny cells floating in the vitreous behind the lens, or a Schaefer sign it's called. And so how you look for a Schaefer sign is you focus in on the lens, narrow the beam, and make sure it's nice and bright, and then you tell the patient to look up, look down, and look straight ahead. And then as they're doing that, you move the joystick backward and forward until you can see the little collagen fibers. And intertwined or floating around those collagen fibers could be those pigment cells or the tobacco dust cells from a retinal tear, or inflammation or blood or something like that. And so after seeing that, then you're going to go to the posterior segment exam of the eye. Commonly, there are two main types of lenses that you'll use. The purpose of lenses in doing a retina exam is to be able to magnify the images in the back of the eye. The common ones that are used are a 78 diopter lens and a 90 diopter lens. I'm using a 78 diopter lens. And there's some little tricks to be able to pick up the posterior segment of the eye or the retina using this lens. First and foremost, I like to do my posterior segment exam using this 78 diopter lens, and I like to do it with my beam not shifted to one side or slanted to one side or the other, but straight on. I feel like that helps me to focus it. Also, what I do is I make my beam a little bit taller and I make it a little bit narrower. And then once I have the nerve and the blood vessels and the macula in focus, then I'll change the size a little bit. I'll shorten the beam down and I'll widen it just a little bit. And that gives me a lit up area that's a little bit easier to see. And then that'll help me to focus in on the nerve and the blood vessels and that sort of thing. So again, when doing the fundus exam from the slit lamp, it's good to start out with a little bit narrower beam, a little bit taller beam until you get the nerve and the macula and the blood vessels in focus, and then shorten it and widen a little bit to start examining around. As a general rule, you're going to hold the lens with 2 fingers, your pointer finger and your thumb, and then you're going to use your pinky and a lot of times your ring finger either resting on the patient's forehead or on the forehead rest itself, the plastic forehead rest. And then the trick of how to do this is you're going to put it up in front of their eye without touching it, but just in front of where their eyebrow is. And then you'll look in through the slit lamp, and once you find their pupil, you're going to pull back a little bit till you see the orange beam come in focus, okay? When the patient is dilated, it's much easier to do. On a non-dilated patient, it takes a little bit more side to side and up and down movement to be able to get the nerve and the retina and the macula into view and into focus. So first things first, now that I've got the nerve and the macula in focus, I'm going to narrow the beam, shorten it, widen it just a hair. First thing you do when you look in the back of the eye is to look at the nerve of the eye. You'll look at the size, you'll look at the optic cup, and you'll look at the borders of the nerve, and you'll look at the blood vessels coming out of the nerve. In the retina world, we commonly see patients that have diabetes and that have macular degeneration or vein occlusions. There's inflammations, there's all sorts of other things, but each of these disorders are commonly associated with something going on with blood vessels. And the blood vessels in the retina most of them come from or start or originate from the optic nerve or travel through the optic nerve. And so you're going to make sure as you look at the nerve of the eye to look at what the blood vessels are doing there too. So we focused in on the nerve of the eye, and after seeing the nerve and looking at the blood vessels, you are going to pull towards the patient's nose, all right? And that will shift the beam over towards the macula. The macula and the fovea are the high-priced real estate. That's where the majority of vision occurs and where the majority of retinal diseases have their source. And macular degeneration, diabetes, when patients have issues with these disorders and many other disorders, when there's swelling or bleeding in the macula, it will be the thing that affects their vision and why they came in to see you with vision complaints. And so again, the key is, and I guess a good point to bring up with that is that these lenses reverse the images up and down and side to side. So the macula is always located temporal or lateral to the nerve of the eye anatomically. However, when you're doing your exam, to see it, you're going to pull nasal or towards the nose to be able to get those into view. So after you see the nerve, you're going to pull nasal and swing the slit lamp over towards the macula to get a good view. After looking at the macula, then generally I will swing and look at the blood vessels. I'll travel along the superior temporal arcade and the inferior temporal arcade and get a good look at the blood vessels. And then I'll look a little bit past that. In general, with the 78 diopter lens and the 90 diopter lens, you can see into the mid-periphery, past the macula a little bit. From there, you're going to take over with your indirect ophthalmic exam. And so those are the basics of the slit lamp exam, looking at the posterior segment of the eye. And now we'll switch over and go to the indirect ophthalmoscopy.